Today we're going to talk about HIV, inshallah, and pregnancy. And we're going to go over how to manage a patient with HIV that is pregnant. So AIDS was first described in 1981. The incident has decreased due to the antenatal testing. Usually the antenatal testing is done in the beginning of pregnancy, either the first or the second trimester of pregnancy. The causative agent, it's an RNA retrovirus called HIV, and there's two types, type 1 and type 2. Most cases are due to type 1. Transmission could be sexually or by blood receiving contaminated blood, or vertical transmission, or from breast milk. Okay. The clinical manifestations, usually it's due to immunosuppression that increase the risk of opportunistic infections and neoplasias. So the patient will come with fever, arthralgia, myalgia, lymphadenopathy, rash, cough, night sweats, nausea, vomiting, headache, or fatigue. The incubation period usually is 6 days. Then the viremia will develop. From viremia to AIDS, it usually takes 10 years. The diagnosis usually is made by the CD4 count, which has to be less than 200. Manifestations of disease progression. So the patients will come with generalized lymphadenopathy, oral hairy leukoplakia, aphthous ulcers, thrombocytopenia, opportunistic infections such as esophageal or pulmonary candidiasis, persistent HSV or zoster lesions, condyloma acuminata, pulmonary TB, cytomegalovirus, pneumonia, Urovisci pneumonia, toxoplasmosis, or CNS involvement that are common. So for the screening, usually we have the opt-in and the opt-out test. Opt-in test, all pregnant women will be given a pre-HIV test counseling. They must agree on the test, usually by written consent. The opt-out test, pregnant women are told that the test is included in the prenatal test, and they may decline the test. So what we usually do here, the Ministry of Health, they usually do the, or what's recommended by the Ministry of Health is the opt-out test. Okay, so the pregnant woman has the right to decline the test. Usually HIV testing is opt-out, no consent is needed, but the patient is told about the test. Screening is performed by enzyme-linked immunoassay, and it's very sensitive. The confirmation is either by the Western blot test or the immunofluorescence assay that is very specific. A woman with unknown HIV status at delivery should have rapid HIV testing, and we're going to talk about this in the coming slides. These tests can detect HIV antibodies in 60 minutes. Positive rapid tests should be confirmed by the Western blot or the immunofluorescence assay. Intrapartum intervention should be limited. So interpartum interventions such as اللي هو السكالب sampling, electronic scalp, operative vaginal deliveries, episiotomies. Even some studies show that patients with HIV shouldn't have epidurals. It's not contraindicated, but you should limit all of these things intrapartumly. Risk factors طبعا عندنا اللي هم IV drug abuse, prostitution, suspected or known partner with HIV, multiple sexual partners or other sexually transmitted disease, or a patient that is having unprotected intercourse with someone who is HIV positive, or unprotected intercourse with a partner that has high risk behavior or having intercourse with somebody that is that has urogenital ulcers or urogenital disease. What to tell your patient if a rapid test is positive. So if a rapid test comes back positive, she might have HIV and the neonate might be exposed. So she needs to do a confirmatory test because this is just a preliminary result and has high false positive rate. In labor, you should start antiretroviral treatment to reduce the risk of neonatal transmission. You have to inform your pediatrics team and stop the antiretroviral treatment after delivery, and no breastfeeding until you have all her results are back and you're sure that she is negative. Numbers you need to know about the HIV. So the neonatal transmission, usually it's 15 to 40%. If a patient is exposed before 36 weeks, then her risk of transmitting the virus is 50%. Days before delivery, it's 50%. Intrapartum, it's 30%, the risk of transmission. With breastfeeding, the risk of transmission is 30 to 40%. If a patient comes in with a rupture membrane or you do artificial rupture of membrane, then her risk is 15 to 25% in transmitting the virus. Um, HIV-1 vertical transmission is 50% and HIV-2 vertical transmission is 25%. Um, and you need to know that transmission with no treatment is usually 40 to 10%. And if somebody is receiving treatment, they are decreasing their risk of vertical transmission to about 1%. So workup, usually you're going to do a hepatic and renal function. Some of them will have hepatic involvement and you will find that their liver enzymes are high. Um, you are going to do a CBC, chest x-ray. You have to do the drug resistant test. So to see if the antiviral treatment that she's receiving is working and it's doing its job or not, or if you need to change the medication or if you need to add a medication. Usually we do our anatomy scans and dating ultrasound. So dating ultrasound will be done early in pregnancy. The anatomy scan will usually be done between 18 to 20 weeks. You have to do TB testing, so a PPD, viral load and CD4, and you have to do serology for the hepatitis viruses and for torch. Um, always don't forget vaccination for pneumococcal and hepatitis B virus in those patients. Usually the vaccinations will be given before pregnancy. So the antiretroviral treatment, so all pregnant women on treatment should continue the same, but stop evivarin if she was on it because it's hepatotoxic and it can cause some congenital anomalies. Pregnant women not on treatment should be started on treatment ASAP. Pregnant women who stop treatment should resume. If no treatment and presents in labor, need initial HIV testing and start zidovudine. All pregnant women on antiretroviral treatment should have drug-resistant testing. So the classes of the antiretroviral عندكم اللي هو nucleoside reverse transcriptase inhibitor, non-nucleoside reverse transcriptase inhibitor, protease inhibitor, entry inhibitors, and the integrated inhibitors. Usually treatment will start with heart, and you can have either two non-nucleoside transcriptase inhibitor and one or one with protease. So it's a combination. Usually the patient is not on monotherapy. You have to be on um, triple treatment. Um, Put in mind that the protease inhibitors can cause glucose intolerance, and the nevirapine can be hepatotoxic. Okay, so patients that are on those treatments, you need to check their blood sugar, and you need to check their hepatic profile. Complications, usually if the CD4 is less than 200, patient can have pneumonia carnii, opportunistic infections, as we mentioned, such as HSV, Mycobacterium, and Candida. Toxo can be as well. Prenatal complications, patients can have complications related to preterm labor or low birth weight or stillbirth. Um, Neonatal neutropenia is common, hepatotoxicity, and long-term hematological complications. Intrapartum management, so HIV precautions, if the patient comes in labor. طبعا الدبل gloving واللي هو الماسك والجاون. You have to put an IV line. You have to send blood work that includes CBC, LFTs, and renal function that include creatinine, BUN, and bilirubin. CD4 and viral load. Repeat her serology for hepatitis B and C. And if you don't have a status for her HIV, then you need to do the rapid testing. Zidovudine decreases the prenatal transmission from 25 to 2%. No ARM should be done, no fetal scalp sampling. Augment the patient to shorten labor. Avoid operative vaginal delivery. Um, Avoid epidural as possible. Okay, it's not contraindicated, but it should be avoided. If the patient comes in with rupture membrane, then start oxytocin to expedite delivery. Usually we do the external monitoring. Don't use internal monitoring with the clip, because then you're increasing the risk of transmission. If she's GBS positive, then you need to treat her. Shorten the second stage of labor as much as possible. If the patient has postpartum hemorrhage, then use oxytocin and prostaglandin. Methergine and ergot interact with the antiretroviral and can cause vasoconstriction. So they are not recommended to treat patients with postpartum hemorrhage that are HIV positive. Usually for indications for cesarean section, so the patient can deliver vaginally. No need to do a cesarean section unless it's indicated, and these are the indications. So if the viral load is more than 1,000, if the patient comes in with no prenatal care, unavailable viral load, and if the patient is on no treatment or has monotherapy. So those are the indications for cesarean section. Otherwise, the patient can deliver vaginally. Postpartum care, usually no breastfeeding because the virus is secreted in the milk up to 6 months. So no breastfeeding and no breast pumping. If the CD4 is low, you may see the antiretroviral. طبعا psychological support واللي هو counsel for contraception. Intrapartum, zidovudine usually is given, so 2 milligrams per kg over 1 hour as a loading dose, then 1 milligram per kg until delivery. If you're in a cesarean section, so until the cord clamp, after delivering el placenta, you can DC the zidovudine. In a vaginal delivery, after the baby's delivered, you can DC it. Neonatally, or the neonates, you should give them the zidovudine 8 to 12 hours post-delivery. It's 2 milligrams per kg every 6 hours for 6 weeks. um, دقيقة هنا كان عندي حاجة أنا أيوة. If the infant, if the mom's viral load is less than 1,000, so prophylaxis should be given to the infant for 6 months. And as we said, you can start it 6 to 12 hours post delivery. If the viral load is more than 1,000 and the mom is considered high risk, then you have to give zidovudine and nevirapine for 1 week. And then you continue on the zidovudine for 7 weeks. You have to check the CBC for the baby as a baseline, and then you have to check it after 4 weeks to compare if there's any hematological involvement, because it can cause, zidovudine can cause anemia and neutropenia to the infants. So just before I take the questions, there's some points I need to discuss. So we said that the breast feeding is not recommended in those kinds of patients. So you can offer the patient either bromocriptine or
Dostinex.
Or cabergoline, to decrease اللي هو المilk production. For breast engorgement, you can offer them as well hot compression, acetaminophen, pump, but don't feed. Okay. Contraception, طبعا the choice is yours. You can use OCPs, you can use Depo, you can use the ring, you can use an IUCD. Condoms decrease the transmission, but the failure rate is about 15%. So I wouldn't recommend that the patient just uses condoms for contraception. The other thing is that with HIV, the bone loss is faster. Okay, so if you're going to give somebody Depo, you need to do a bone scan to see the bone mineral density. And you can put the Depo-Provera as the low on your list. Okay. Other things that I wanted to discuss. So the counseling for a patient that is coming with HIV. So pregnancy planning. So before getting pregnant. So if you have a woman that is positive and a male that is negative, okay, so you can offer them to get pregnant to decrease the transmission. These are their options: either an IUI for 3 or 6 months. IUI is an intrauterine insemination with partner sperms طبعا, or refer to an infertility clinic if no pregnancy within a year. Okay, so if the female is positive and the male is negative, you can try IUI. If they don't get pregnant, then you can refer them to an IVF clinic. Putting in mind that the sperms for the male are normal. Okay, so the sperm count and motility are suitable to do intrauterine insemination. طبعا هذه guidelines أجنبية. طيب, it's SOGC, it's Canadian guidelines or ECHO guidelines. So one of the things that they discuss, if you have a single female that is positive or a same-sex couple, طيب, so you will offer IUI with an HIV negative donor sperm. And if they don't get pregnant, then they can do IVF. So هذا إذا كان same sex couple, or إذا كانت single seeking pregnancy, so she's going to use a negative HIV sperm donor. If the male is positive and the female is negative, okay, so you can do IUI with sperm washing. So what they usually do, they put the sperms in the centrifuge, and they try to remove as much virus from the semen fluid. Or you can do IVF with ICSI with sperm washing. طبعا in our religion we don't use donor sperms, but it is an option as well. And you should give the male antiretroviral treatment prior to IVF to decrease the plasma viral load and to decrease the risk of partner transmission. If you have two males, so same sex, and they're both positive, you refer to HIV, to ART or an infertility clinic to do اللي هو surrogacy with donor sperms. If you have a male that is positive and a female that is positive, then they can do timed intercourse after receiving treatment to suppress their viral load. هذه واضحة الأشياء اللي قلناها؟
دكتورة ممكن آخر نقطة تعيديها؟
طيب. If a male is positive, HIV positive, and a female is positive, okay? They can have normal intercourse to get pregnant with no contraception, with no barrier, with nothing. But before that, you need to give them both antiretroviral treatment to suppress their viral load. So the risk of transmission to the baby will be low. واضحة؟
Yes, now it's clear. Thank you.
Anything else? أي سؤال تاني على هذه البوينتس؟
دكتورة السلام عليكم.
وعليكم السلام.
Thank you, Doctor, for the lecture. بس I want to ask you for this opt-in test and opt-out test because as I know the HIV screening test for pregnant ladies is verbal consent. ده the first question. Second question before I give the question.
It's verbal إيش؟
verbal consent.
verbal consent ايوه. So الopt out هو verbal consent. Okay, الopt out هو verbal consent. انت you're gonna tell the patient that you're gonna do HIV testing والpatient has the right to refuse it. طيب وهذا اللي احنا بنسويه هنا. الopt in لازم يكون في written consent.
Okay.
And at opt-in, we don't use it here. And even in North America, they don't use it.
Okay. طيب دكتورة لو patient she did the test and she came positive and the husband is negative.
Okay.
Should we tell the husband or we are the one or what we will do for this case?
If the patient is positive and husband is negative.
And husband is negative. And he don't know that she is positive and he's negative.
Well, okay. First of all, and for counseling, أول شيء حتجيب the patient on her own without the husband. You're gonna discuss the results with her, okay? And then you have to tell her that you are gonna tell the husband in her presence because he needs to know, because he's gonna be exposed. And HIV, it's not like a flu virus, right? So it needs to be discussed with him, but after discussing it with ethically, after discussing it with the patient, letting her know that you are going to discuss it with the husband.
Yani we can discuss with the
husband. If the husband was positive and the wife was negative, you have to discuss it with the husband, and then you have to tell the wife that the husband is positive. Usually in some hospitals, there's like a committee that they will sit with the couple and they discuss the results with both couples, especially for the HIV and hepatitis C and hepatitis B, the viruses that are sexually transmitted and it affects a person's life.
اوكي ثانك يو.
ممكن اتداخل انا شويه يعني كلمتين كده؟
اتفضل.
بس ابغى اوضح حاجه عن متطلبات وزاره الصحه الان. مثلا antenatal screening you have to do HIV. Any pre-op procedures that you are going to do in your hospital you have to do HIV. So it's it's متطلبات الصحة whether patient agreed or disagreed, they have to have the HIV for protection of the staff. I don't know if this is going to continue, بس نحن يعني من تقريبا حوالي 2 ولا 3 سنوات it became mandatory إنك تسوي HIV for pregnant ladies, and it's mandatory to do HIV for any procedure you're going to do. I know in North America you have to have a consent, but here you have to tell them that this is متطلبات وزارة الصحة, and they have to do it. الطريقة الثانية حكاية إنه how to counsel them. Usually the hospital will tell them that you have a virus and you have to you will be get contacted by وزارة الصحة. وزارة الصحة they usually do that. They في general lab they make sure that it's positive, and then they will talk to the couples personally, and they discuss with them whether they need treatment or not. يعني هذه يمكن مختلفة شوية عن North American practice, لكن this is what's happening now in Saudi Arabia. بس يعني حبيت أقول الكومنت هذه عشان الناس. I don't know if all the hospital obey to the rule of antenatal, but in some of the private hospital, the MOH is behind our back because of this. You have to do HIV. You have to do HIV. بس شكرا.
Thank you دكتور. شكرا.
كنت أنا كمان بقول لكم حاجة. طيب بالنسبة للبيشنتس اللي هم you do the screening and they're negative. طيب and they're pregnant but they're engaged in high risk behavior. طيب إيش يعني engaged in high risk behavior؟ يعني لو مريضة هي negative وزوجها مثلا positive، ولا هي negative ومثلا عندها واحد من الريسك فاكتورز اللي احنا اتكلمنا عنها، you have to test her every trimester. هذه واحدة من الأسئلة كده اللي في الام سي كيوز أحيانا يجيبوها. أي سؤال تاني؟
دكتورة في الأوسكي بيسألونا عن الميديكيشن.
في الأوسكي أيوة، لازم تعرفي اللي هي الكلاسز ال5 كلاسز، ولازم على كل كلاس تعرفي واحد مثال على كل كلاس. الزايدوفيدين لازم تعرفوا انترابارتم الدوز حقته، والدوز حقت اللي هو النيونيتس، لأنه هو الكومنلي يوزد، هو أكتر واحد بيستخدمه أو أكتر واحد يستخدم.
السلام عليكم دكتورة، مرحبا. دكتورة أنا بس أبغى أسأل عن الزايدوفيدين، إذا هو روتين بيتعاطى لأي HIV patient intrapartum أو بس للبيشنتس اللي هم ما كانوا following up ولا ما كانوا على medication قبل كده أو newly discovered HIV. what about إذا هي كانت أصلاً patient على HRT من قبل البريجنانسي وviral load undetected و CD4 count is good، فوقتها نعطي لكل أحد ولا لمين بالضبط؟
الزايدوفيدين من الأدوية اللي يتعاطى ل all comers with HIV intrapartumly، بس عشان it decreases the risk of transmission للفيتس.
شكرا.
يعطيك العافية دكتورة. بس about the cord clamping، نعمل delay للcord clamping ولا early؟
لا ما تعملي delay عادي. الcord clamping اللي هو early cord clamping، once انك انت تسوي الcord clamp you DC الزايدوفيدين.
اوكي شكرا، يعطيك العافية.
هذه البوينت اللي كانت حقت الcord clamping والزايدوفيدين. in once you clamp سواء في Cesarean ولا في vaginal delivery you stop الزايدوفيدين. أحيانا إحنا بننسى للأمانة إن إحنا نوقفه لما we clamp the cord، but you make sure after you're done إنه الزايدوفيدين is DC'd. أي سؤال تاني؟
دكتورة في أسئلة في الشات.
طيب نفك الشات يا مدام. هدول يعني اللي يستحوا يتكلموا؟ and the side effects ما قادرة أطلع لفوق. طيب who is the infected, the female or male, to test the female in every trimester? So if the female is negative and she's engaged in high risk behaviors, يعني لو هي negative وزوجها positive لازم كل trimester you check her status. أو لو كانت هي negative وعندها any of the risk factors اللي تكلمنا عنها, she needs to be tested every trimester حتى لو أنت لما سويتي لها screening in the beginning of pregnancy and she was negative. For non-HIV mother on treatment, when breastfeeding benefit to baby overcome the benefit of baby prevention from HIV, it is in poor and undeveloped areas only. So HIV, this virus is secreted in the breast milk. طيب, what rate of transmission من breast milk is very high. It's about 40%. احنا قلنا from 30 to 40%, which is very high. That's why it's contraindicated to breastfeed or to use أصلاً breast milk. يعني you can pump breast milk and you have to discard it. ما تقدري تستخدمي. Please, we need recording because we joined late. طيب اللي فوق الأسئلة ما قادرة أشوفها اللي قبل الساعة 8.
طب دكتورة في البرايفت كمان أنا جاني, can you repeat the 5 classes that we need to know them?
ال5 classes مكتوبة في ويليام في جدول ولا أحلى منه. النيوكليوسايد transcriptase inhibitor واحد من الexamples عليه اللي هو الزايدوفيدين. النون-نيوكليوسايدase transcriptase inhibitor زي النيفرابين. طيب, البروتياز inhibitor زي الرايتونافين. entry inhibitor وبعدين الانتجريتد inhibitor. ماني حافظة صراحة عليهم some examples, بس في ويليامز محطوطة في كده جدول مرة حلو, وكل كلاس وتحته يمكن 5 أدوية. أنت احفظي الكلاس وواحد من الأدوية. pre-exposure and post-exposure prophylaxis. ما فهمت إيش السؤال ده فيصل. Which patients will allow for vaginal delivery? So إحنا قلنا إنه vaginal delivery unless there's a contraindication for vaginal delivery. Indications to do a section إذا كان الفيرال load أكثر من 1000. إذا كان الفيرال load أقل من 1000 you can proceed with a vaginal delivery.
أنا سؤالي يا دكتور لو anybody had a contact with HIV positive patient, هل في أي prophylaxis to be given after?
So الناس اللي they get contact ولا مثلا إذا كنت أنت operating على a patient that has HIV ومثلا اتجرحت أو جاك needle prick ولا كده, they usually test the doctor ولا the person that was exposed, وبعد كده يدوا له واحد من الريتروفيرال medications for 28 days. وبعدين they retest him again after 3 months.
بس لو ما في needle prick أو أي شيء زي كده they won't have anything, لا testing ولا prophylaxis.
exposure يعني إيش قصدك exposure؟ أنت دخلت على patient HIV يعني you're delivering the patient؟
مثلا.
طيب هو ما هو airborne يعني ما حينتقل عن طريق الهواء، هو زي ما تكلمنا إحنا الترانسميشن إما عن طريق البلد أو sexual transmission or vertical transmission. فلازم واحدة من هذه الثلاثة أشياء تصير، يعني يا إن واحد أخذ blood في infected، يا عن طريق الانتركورس، يا عن طريق اللي هو الفيرتيكال ترانسميشن، وتكلمنا عن اللي هي الهاي ريسك اللي هو using needles. يعني لازم يكون في source of the virus دخل في جسم الشخص هذا اللي نقول عليه exposed.
Okay, doctor. Thank you.
You're welcome. السايد افكتس هو في بعض الادويه الزايدوفيدين السايد افكتس يوجوالي في النيونيتس انه بيسوي هيماتولوجيكال manifestations زي الانيميا، نيوتروبينيا، ثرومبوسايتوبينيا and that's why you need to do CBCs for them. قلنا البروتياز inhibitors بيسووا glucose intolerance. النيفربين بيسوي اللي هو بيكون hepatotoxic so you need to check اللي هو liver profile حقت البيشنت. بعض الانتيريتروفيرال medications بيسووا congenital anomalies. بس هذه بالنسبة للسايد افكتس حقتهم.
طيب دكتور معلش سؤال ثاني. أنا فهمت من الشرح إنه النيونيت للبيشنت اللي عندهم الفيرال لود لو أور هاي. اللي عندهم لو للنيونيت بياخذ بروفيلاكسيس for 6 months.
6 weeks.
6 weeks. أوكي أنا سمعت 6 months. أوكي thank you.
Every 6 hours for 6 weeks.
أوكي.
الدوز حقتها تبدأها من 6 to 12 hours after delivery. الدوز 2 milligrams per kg every 6 hours for 6 weeks.
Okay, thank you.
You're welcome. اللي 6 months إنه الفيرال will be secreted في البريست milk for 6 months.